Hello, my name is Arunima Vijay. I'm a third-year medical student at the University of Florida, and today I'll be presenting a case on disseminated histoplasmosis of the tongue that presented 3 decades after initial exposure in Latin America. I'm presenting this case in collaboration with the Department of Infectious Disease here at the University of Florida, as well as the Universidad de Antioquia, Facultad de Medicina in Colombia. A little bit of introduction before we get into the actual case. So histoplasma is a thermally dimorphic fungus, and it exists as 3 distinct varieties. The one that we're most familiar with is Histoplasma capsulatum. It's endemic to the Mississippi and Ohio River Valley regions of North America, as well as Central and South America. So this case pertains to a Latin American strain that disseminated to the tongue in an immunocompromised veteran who had previously lived in endemic regions of Latin America 3 decades prior to his initial presentation. He presented to us as a 72-year-old male for a 2-year history of a worsening, painful right tongue ulcer. The right tongue ulcer had limited his ability to chew and had also caused him odynophagia. It had progressed to the point of him being unable to consume solids and liquids, resulting in unintentional weight loss. When we took his medical and social history, we found out that he had controlled diabetes mellitus as well as psoriasis. Of note, he started taking adalimumab for his psoriasis about 2 years prior, and this was also at the time of the onset of the ulcer. Social history revealed that he had lived in rural regions of Panama, Honduras, and Nicaragua from 1987 to 1991 when he was serving with the U.S. Air Force. On physical exam, we noted a 2-centimeter ulcer on his right lateral tongue. It was present with edema and erythema. This brings us to his diagnosis as well as his inpatient and outpatient treatment. So we took a biopsy of his tongue ulcer, and fungal culture of that biopsy grew a cream-colored fungus. Microscopy also revealed tuberculate macroconidia, and serologic testing confirmed it as histoplasma via mycelial complement fixation. This biopsy was sequenced, and it was confirmed as Histoplasma capsulatum, var Latin American group A, also known as LAM-A. This is Histoplasma supraamericanum. After the diagnosis was confirmed, CT chest without contrast was ordered for the patient, and this revealed a 1-centimeter calcified nodule in the right lower lobe of his lung. This confirmed the diagnosis as histoplasma, as well as confirmed his initial exposure to histoplasma, likely when he was living in those endemic regions of Latin America. Treatment was started, and treatment was liposomal amphotericin B. The amphotericin B resulted in an immediate reduction of his edema and pain, and he was monitored on therapeutic dosing for 1 week in the hospital. The patient was discharged with oral itraconazole 300 milligrams BID for 6 months afterwards. At 1-month follow-up, he had complete resolution of his odynophagia as well as a reduction in his ulcer size. At 6-month follow-up, he had complete resolution of his ulcer. So the patient continues on itraconazole and is followed by our Department of Infectious Disease, but he's doing much better. The right-hand side of this poster shows clinical images that pertain to the case, as well as a little bit more background about the particular strain of histoplasma that he encountered. Figure 1 shows the ulcer when he first presented to us on his right lateral tongue, and the right side of Figure 1 shows the resolution of this ulcer at his 6-month follow-up. Figure 2 is the image of the CT chest that was ordered, and it clearly shows a 1-centimeter calcified nodule without edema in his right lower lung. Figure 3 demonstrates that the culture of the tongue biopsy grew a cream-colored fungus as seen in the top image, and the bottom image reveals the microscopy that was seen, which of course is tuberculate macroconidia, pathognomonic for histoplasma. Figure 4 is a figure adapted from Taylor et al. That shows the specific strain of histoplasma that he likely encountered. So this is LAM-A, which is represented by the navy dot, and as you can see that this is very common in the central regions of Latin America. Figure 5 is a heat map from the CDC, and it shows the endemic regions of histoplasmosis. So histoplasmosis is not only endemic to North America, but it is also endemic to Central and South America, as we've discussed in this presentation. We did conduct a literature review after meeting this patient, and we found 5 other cases of histoplasmosis disseminated to the tongue. Of note, none of these other patients were taking adalimumab, so this is actually the first case of disseminated histoplasmosis to the tongue in the context of adalimumab as the immunosuppressive therapy that likely caused this to become disseminated. So this brings us to the conclusion of this poster. In patients who are starting immunosuppressants, it is extremely pertinent to take a very thorough social history. Doing so allows us to understand if patients may have ever been exposed to these strains of mycoses, and doing something as simple as an X-ray can prevent future dissemination. Thank you so much for listening, and thank you to the Department of Infectious Disease here at the University of Florida College of Medicine, as well as the Universidad de Antigua from Colombia. Finally, thank you to the Florida ACP for letting us share these findings and present. Thank you.